Okay, so hello, my name is Keisha Mayhew, and this is my table of evidence for hourly rounding as a fall prevention strategy in older acute care patients. So the first article we have here is Turner. Okay, sorry. Of course. Okay. So first we have Turner. Is a sampling method is a convenience sampling. There is 60 hospitals units. Sampling characteristics are and eligibility criteria. It was included in the US that responded to surveys on fall prevention practices. Hospitals were eligible if they were participated in the studies and provided usable responses. Incomplete surveys were excluded. So the assignment to groups, it's not applicable. There was observational survey study only. We have a setting in acute care hospitals across the United States. So this one is for Turner. Next is Tucker. So on Tucker, the sampling method was purposive sampling. There was 27,000 plus patients, days across orthopedic units. The sampling characteristics with eligibility criteria included patients admitted to the participating orthopedic units during the study. We excluded patients outside the orthopedic service or units not involved in the hourly rounding interventions. For this one, assignments to groups, it was a quasi-experimental. The setting was orthopedic inpatient units in a hospital system. So that one is a level of evidence. Then we have McLean. So here we have McLean. This was one of our qualitative articles, so qualitative paper. For this one, our sampling method was purposive. It was a purposive sampling. The sample size was 75 participants. It said data from 50 revealed 3 key terms, but there was 75 total for this one. Characteristics with eligibility criteria included multiple stakeholder groups involved in a fall prevention. This included patients, family members, nurses, physicians, hospital staff, and administrators. So for this one, participants had to have direct experience or involvement in fall prevention implementations. Those without relevant experience were excluded. The assignment to groups is not applicable. There's no grouping or randomization. Our setting was acute care hospitals involved in fall prevention program implementation. So that was for McLennan. And then last but not least, we have Radecki. Okay. For Radecki, the sampling method was purposive sampling again. There was 11 patients for this one. The sample characteristics with eligibility criteria included hospitalized adults with patients with patient experience related to falls or fall risk, excluded patients unable to participate in interviews due to cognitive impairment, illness severity, or communication barriers. So this one is the assignments to group was not applicable because there was no grouping or randomization. The setting, again, was an acute care in inpatient hospital setting. Okay, so here in Radecki, there was some quotes here. Many found the interventions such as the bed alarm and gait belt useful for a nursing team. Some patients did not find the intervention useful. We have the second major theme, how I see interventions, describes how patients see the fall interventions put into place by the nurses. Some of the patients were stating they didn't want to let the nurses down. It was they were insecure, maybe unsure of themselves. They wanted to protect themselves and feel safe. This is how the theme of this was how I see myself. In Radecki, we also have the aim of the study was to describe patients' perspective of fall prevention in an acute care setting to aid the design of patient-centered strategies. Going back to McLennan, let's see here. McLennan, yeah, we're at the top. The data was analyzed using an inductive thematic approach. It says 50, there was 75, like I stated. Fall prevention was priority. Disempowered stakeholders were participants expressed feeling frustrated and powerless with fall prevention in acute care settings. Shared responsibility may be a solution. Key stakeholder groups agreed that hospital fall prevention is a priority. However, challenges related to the role perception, competing priorities, workforce pressure, and disempowerment mean fall prevention may often be neglected in practice. There's a semi-structured interviews and focus groups were conducted with staff and patients and family members. 2 large Australian acute metropolitan public hospitals is where these interviews were taking place. Participants were sampled purposely for maximum variation in experiences of the hospital fall. A qualitative description design was selected for its utility in producing results as close to the data as possible to practically guide clinical practice. There was some data collection here. Interviews and focus groups were conducted in person on site in 2 hospitals. The interviews were focus groups were audio recorded and transcribed verbatim. It included 35 multidisciplinary staff members and 12 patients and 3 family members of the patients, okay? I think that one is what we have for McLennan. Touching back on Tucker. There we go. Touching back on Tucker. The purpose of the study was to evaluate feasibility of adapting and translating a SNRI to reduce the risk of incidents of patient falls or on 2 orthopedic inpatient units. Okay, so 2 orthopedic inpatient units. Using the repeated measure design, fall risks, rates, and assessment data were collected at baseline during a 12-week SNRI implementation and 1 year following implementation. So fall rates declined during the SNI border trend, yet a year follow-up rates drifted back towards the baseline. They appeared to reduce fall rates initially, but fidelity to the SNRI implementation and documentation was variable, and fall reduction gains appeared lost after a year. So that goes back to stating that even though initially they put it in place, it worked, and then after a while it went back. So the setting for the study included 2 29-bed post-operative orthopedic units in a large academic medical center in the Midwest of the United States. Not sure, that one shouldn't have been highlighted. Here we go. The number of falls per 1,000 hospital patients. There was 2,229 hospitalizations during the time frame studied. Observed fall rates were 1.8%, 0.8%, and 1.1% for the 3 periods respectively. The number of falls per 1,000 hospital days was 4.5, 1.6, and 3.2 for the 3 periods. The 2 secondary aims were examined. These included comparing and contrasting profiles and patients who fell during a baseline period, during the rounding intervention period, and during the 1-year follow-up period. There was a lack of clarity. Documentation is an added burden. Why our patient care unit placing this in a context with other patient care changes. Contextual factors included. Contextual factors influenced the SNR implementation, including the reality that best laid plans may be thwarted by more important practices on concerns. A number of clinical realities influenced the fidelity of the intervention, and that was for Tucker. Let's see, we can go back to Turner. So Turner was our first one. This is results of 60 units. 43% were medical units and 57 were medical surgical units. They scheduled toiletry hours so that there would not be falls. Publicly posting fall rates was more consistently used than having a multidisciplinary huddle. So they posted them instead of just huddling them alone. Keeping a patient's room door open, having signage outside the room, and having the patients wear a fall bracelet were all implementations that they did to keep their patients safe. Units had a median bed size of 31, so 24 to 36. The median number of patients in the unit was 24. Most units were located in nonprofit and urban hospitals. The sample had an even mix of magnet designation and small and teaching hospitals. There is a lot of information highlighted here, so I don't want to bore you with all that. Essentially, there's bed modifications, patient monitoring, and patient safety here, as well as educational. Just a few different percentages to kind of give you some information there. They did post fall rates or use dashboards to display fall rates. Units consistently performed nurse huddles and audits of falls for this practice. In discussion, we have units with similar patient populations still vary in the use of fall prevention practices. Units varied in access to resources such as consultation from specialties. Let's see, that is that for that. Okay, so there is my level of evidence, and there is my thing. Thank you for your time.